about to experience Healthline, a show where doctors from 𝗥𝗲𝗹𝗁 interact with you for a healthy, uplifting lifestyle, moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
Hi, everybody, and welcome back to Healthline with 𝗥𝗲𝗹𝗁. I'm your host, Nicole Jacinto. It is June 12 here in the Philippines and June 11 in other parts of the world, but whoever is watching wherever and whatever time you watch this, because you can watch it on Facebook and on YouTube as well. Anytime you want to, just access it and keep watching our show, keep getting information from the best doctors in town here in Metro Manila. And even if you don't live here, you can learn so much. And if you decide to have some procedure, you can come to the Philippines and do it. There's as you see with the doctors we're talking to, they are advanced. The 𝗥𝗲𝗹𝗁 medical center is very advanced and has all the equipment we need. And we are talking about kidney stones today. But before we get back to Dr. Peñaranda to talk about some of the equipment that's used to diagnose kidney stones, there's more good news from 𝗥𝗲𝗹𝗁. Congratulations, 𝗥𝗲𝗹𝗁, because they have an outpatient surgical suite launching. They have recently unveiled their newest facility, and this newest facility is the Outpatient Surgical Suite, or the OSS for short. Now, the OSS caters to minor surgeries that do not require general anesthesia. So, when with the state-of-the-art operating rooms in the OSS offers more procedures to patients. The OSS serves a vital purpose because it relieves the congestion in the ER and also surgical suites in 𝗥𝗲𝗹𝗁. So the ER can focus on critical patients. The medical teams in the ER while the surgical suites can concentrate on major surgeries. Now, this helps or enables 𝗥𝗲𝗹𝗁 to provide affordable yet quality healthcare with the ability to meet patients' needs effectively. That's really true, because if a hospital is too crowded and you need an outpatient surgery procedure, at least now 𝗥𝗲𝗹𝗁 is an area where they focus on this. You may not need anesthesia, or it's an in and out. Yeah, you go in and out. You don't have to go through the whole thing of waiting. And the ER, at least it's freed up for those patients who really need the emergency. And also the operating rooms are free. Are free. I have been in the operating rooms of 𝗥𝗲𝗹𝗁, I have to admit, and they never got as crowded as some other operating rooms, but I can see how much it would help. So, okay, thank you and congratulations on the Outpatient Surgical Suite launching, 𝗥𝗲𝗹𝗁, and for short, that's called OSS. Now, if you want to more know about it and inquire about it, you can reach 𝗥𝗲𝗹𝗁 at 632-8888-8999. Okay, that the extra 8 that was put there a few years ago when all the phones here changed always confuses me. Hello, Dr. Peñaranda. Thank you for being so patient. We were just talking about the OSS, which I'm sure you know about because you are part of the hospital. And okay, let's get back to, speaking of like diagnosing and all that and equipment. What type of tests are used to evaluate kidney stones? I know you mentioned the X-ray, the ultrasound, and the CT scan. Now, for you, doctor, when do you decide that I'm just going to X-ray the patient? That's all I need. Or, I'm going to do an ultrasound, or I'm going to do the CT scan. How does that happen?
Okay. So between ultrasound, X-ray, and CT scan, of course, you have to consider some contraindications to doing a CT scan.
Yes.
As we know, CT scan contains it contains radiation. It gives a patient radiation, So radiation usually is not offered to pregnant patients, that's for sure.
Okay, so
each time a patient is going to undergo CT scan, they're always asked, by the staff, are you pregnant? Or
something like pregnant, yes.
Yeah, that's true. Now, for the accuracy, of course, the highest diagnostic yield would be a CT stonogram. But if that is relatively contraindicated or absolutely contraindicated, we could use an ultrasound. No, an ultrasound can pick up stones also. No, it can, and of course, no, the X-ray of the kidney, uterine, bladder. No, we could also have information whether the patient is having kidney stones or not. But for the information of everybody, the basic clue, to whether you are having a kidney stone, for example, in patients who are younger, when your urine, develops red blood cells, when it shows red blood cells, and usually, if you are a stone former before, and then your urinalysis maybe like in an annual PE will show red blood cell, so that is something to be worked up for or something to be explored. When you say red blood cell, it should be more than 3 red blood cells per high power field.
Should be more than blood cells.
That is in the normal urinalysis report. Of course, the urine pH also of the urinalysis is very important. Most likely, it can discriminate the urine pH between a calcium stone and a uric acid stone.
Oh, okay.
By the pH, because pH of less than 5.5, usually you are dealing with a calcium stone, which is the most common kind of stone. But your urine pH is like 6 all the time, most likely you are dealing with uric acid stone. That is according to a study done 5-6 years ago. Yeah. But of course, we have to confirm it with ultrasound, X-rays, and CT stonogram.
Okay. Sorry. No, go ahead, doctor.
I was to say that we all have it here in MMC.
Okay. Okay, so doctor, if a patient came to you and you suspect that they have a kidney stone or kidney stones, the first thing you would do actually would be to take some blood for a lab tests.
Yes.
Okay. So they're coming to you with excruciating pain, and then you suspect they have kidney stones, or they may even know or suspect that they have it, and or they may have gone to a doctor and another doctor, and the doctor referred them to you. No, because they suspect they were okay. So I think see Dr. Peñaranda, maybe it's a general practitioner, their family doctor, and the patient is like, my back really hurts, and when I pee, So one of the first clues really you're saying is when you have a stone, there is blood in your urine. So basically, what do you do? There are 2 lab tests that do you also take it from the blood? So first, it's actually a urinalysis. You take. Okay, so the patient, okay, will give you a sample of their urine, and just to again reiterate to people out there, the sample that you give when you, and correct me if I'm wrong, doctor, because from what I know, when you first start to urinate, don't get that as a sample. Get the middle stream, the middle.
Correct.
Okay. Okay, so
for women, excuse me, Nicole.
No, go ahead, please. Let us know, please.
For women, because more often than not, when you are being told to get a urinalysis, sometimes the healthcare workers or the technicians, they usually do not instruct properly,
Yeah.
So the best way for a proper collection of urine is usually for women, They should wash properly with soap and water and dry, and then they try to catch the urine midstream.
Okay.
A sterile bottle. Usually they get it from the laboratory or from the hospital's laboratory.
And of course, doctor, you said wash with soap and water. Don't use the feminine hygiene products, just soap and water before you.
They can use the feminine hygiene products, but it can be simpler. and you use
Yes.
soap and water.
Yes, the soap and water. And then okay, so that's a great point, doctor. Okay, wash properly, use soap and water or whatever if you have some feminine hygiene products, and then go and catch your urine in the middle of the stream in a steril.
Correct.
Yeah, I noticed they don't remind, they don't tell you're correct. They don't instruct patients not to do that, female patients. And then also, uh, also, I guess you should know to tell the doctor if you are menstruating. You're menstruating because, I mean, if you have, I can't take the urinalysis right now because I have my period. I mean,
Correct.
because there will be blood there.
Yes,
And
correct.
definitely blood cells, as you said, the clue is that when you check it, if it's more than 3 blood cells, and that's when you start saying, okay, this person has a kidney stone. How about for men, doctor? How do they also have to catch it in midstream? What's your recommendation?
Yes.
For-
Yeah. All patients know who are going to catch urine for urinalysis should catch it midstream.
Mhm.
Midstream.
And anyway, I mean, you're going for you're giving your sample of urine. Some people are like, ew, it might hit my hands, but urine is, is, well, you
It's
can wash
supposed to
your
be
hands.
sterile.
Yeah, urine is sterile when it comes out, right? So actually, clean when it comes out or sterile, and then you can wash your hands anyway after. So, thank you for reminding us, doctor, of the proper way to do it. And after you take the urinalysis, do you or along with it, do you do other lab tests first, like take the blood to see things
Yeah.
before the person takes tests like X-ray, CT scan, all that?
Yeah, I usually request for a metabolic panel, which
Mhm.
includes your electrolytes.
Oh,
Of course, your electrolytes. It will include your total calcium,
Mhm.
your uric acid,
Mhm.
and of course, it is important for a doctor to elicit a history of any systemic disorders, like, for example, disorders of calcium homeostasis or calcium balance.
Yeah.
When a patient has primary hyperparathyroidism, is very important, because conditions like that, it's usually accompanied by extra renal calcitriol production, meaning there's excess calcium production, and sometimes it deposits, on the what you call this, on the kidney. So it's very important that we get all those metabolic panel to give us an idea also, whether this patient,
It's great, doctor. Like you do a complete thing. When you say metabolic panel, is that like a spec 23?
yes,
Okay,
correct.
so that would be something where you have to fast.
You have to fast for
How many
12
hours,
hours.
doctor? 12 hours. Okay, not even a sip of water in between.
You can.
A little bit.
A little
Okay.
bit, yeah.
And so, you should get to the hospital in time or after that. It's kind of funny. I just talk about the funny side where, you fast and then you don't drink so much water. And then when they take your blood, and then when it comes to the part where you have to urinate, you're like, oh, give me some water so I can urinate.
Yeah, that's true.
There's things that we all go through, and we're all kind of used to it. But taking the blood test is also very important because
yes.
you got electrolytes, you look at
kidney function.
Do you also give, if you suspect that they have kidney stones, do you order an EGFR?
Oh yeah, this is very important.
Okay.
Normally, the GFR is computed by the doctor.
Okay.
We have the formula for that, or it is found in our app, in our phone. We call the 𝗥𝗲𝗹𝘆, for those kidney functions who are stable. But the lab, usually they use another formula based on your age, your height, your weight, creatinine.
You can't lie and say you shouldn't lie and say, I'm 120 pounds. I think they should bring her and take your weight also, so that because a lot of people be like, actually, I don't know how much I weigh, and then you're wishful thinking that you're lighter than what
That's
it's
right.
doctor. So they consider your height, your weight. Do they consider age also? Did you say age?
The age, yes.
Okay. All right. And then, so the urinalysis is very important. The blood test is also very important. And with the urinalysis, you did say that you will also check the pH levels, and you can, if it's acidic, then it's probably the uric acid type of stone, probably
the calcium.
Calcium type of stone. And if it's not acidic, or it's at 6, then it may be the uric.
But it's not definite, Nicole.
It's not definite. You have to evaluate.
Yes.
Go ahead, doctor. Like you have to evaluate it. That's why you can't just do it like look at your own.
And the thing about urine pH, sorry, when you do a specific, because normally you find the urine pH in a normal urinalysis, no? I mean in a regular urinalysis, no? But when you really want to check for the acidity, no, or alkalinity, sorry, check for the alkalinity and acidity, you should instruct your patients to fast for 10 hours.
Yes.
And then collect it with 10 ml of mineral oil.
Okay.
Sorry.
So 10
ml of mineral oil, because you wanted to prevent the escape of CO2, no, in urine.
Okay.
It is also important for you to fast, since when you eat, no, it will give you a false urine pH if you do not fast, because sometimes food, no, makes your urine alkaline, and maybe you do not fast, no, and if it's alkaline, then you're going to have a wrong impression that you're dealing with something else, no?
So basically, prepare properly for the tests, listen to the instructions, because some people will break the fast and say, uminom naman ako ng gatas or something like that. You know, you're not supposed to, or kumain lang ako ng konti. And that's the reason why, that's one of the reasons why they request you to fast. You can see all the other possibilities also with the blood test.
Correct.
Okay, thank you, doctor. That's very informative. You know, even just to know you have kidney stones, if you want the best information about your own health, go to doctors like you who will, combine the results of the urinalysis with the GFR, that's to get the kidney function, and with the other blood tests, and the results of the other of the blood test. And isahan lang naman yun, doc, diba? They only get your blood once.
Correct. Yeah.
And then do you decide to do the CT scan and X-ray after that, or you just do it along with you get everything already, all the information you can?
Yeah, usually you ask them to get a blood test and then the imaging study to follow. So
sorry, doctor, I didn't mean to interrupt you.
It's okay. Maybe they can do it in one day because they are instructed to fast. So maybe after fasting, of course, they can eat already. After blood is extracted, they can eat already. And then after that, they can proceed with their imaging study. The ultrasound of the kidneys, and also the CT scan or the X-ray.
And doctor, you said you would you recommend the CT scan immediately if a patient is not pregnant or has other considerations where they shouldn't be taking radiation?
Yes.
So that it's clear. How about, how does one get the CT scan? How would a patient prepare for it?
Actually, CT scan, CT stonogram, no?
CT stonogram.
CT stonogram can be done in less than 5 minutes. It's so quick. And some of my patients, I usually help them. They can be a walk-in patient. Because if it's really urgent, of course, I ask a little favor from the radiology. If the patient is really in pain, I ask a little favor from the radiology service, maybe if they could prioritize, it was patients who are needed to be diagnosed immediately, because of course you have to think of other causes also, not only kidney stones when your patient presents with pain in the abdomen, but there is a precise manifestation of kidney stone which a doctor, an experienced doctor, could easily pinpoint. That relates to kidney stone.
And so, doctor, we've been talking about kidney stones, and in and of itself, a kidney stone or a bunch of kidney stones can cause a lot of pain and blockage. And as you said, the urine, a kidney can get swollen. Can you tell us, doctor, can it also cause complications to the body, like especially, let's say, kidney damage?
Definitely, yes. No? Kidney stones or nephrolysis, as you say, may lead to persistent kidney obstruction. No? And it could cause permanent kidney damage if left untreated. For example, if urine is infected, proximal, meaning proximal nearer to the obstructing stone, this is already considered a urologic emergency, and then it require a rapid decompression. No? When you say rapid decompression, dapat makalabas na yung ihi, no? Because maalis na dapat ang stone. So, of course, this can be done when you refer a patient to a urologist, because the nephrologist cannot do surgical procedures, no?
Okay. So you work hand in hand with a urologist, even
correct. Yeah.
So the females and males who come to you, a nephrologist, and let's say you detect that there's an emergency already. For you, that's a situation because the kidney's starting to be damaged, the urine needs to come out. You call a fellow urologist and surgery is done.
Yes.
Okay, doctor. We just have to take a short break. But when we get back, let's talk more about the treatment options and that surgery that you mentioned that a urologist does for you or with your guidance. Or are you all in the same room? Yeah, you're all together. Okay.
Yeah.
So we'll just
work hand in hand. Yeah.
We work hand in hand. That's great, doctor. Okay. That reminds me of some of the TV shows with doctors, with the doctors operating on them. I wonder if those are realistic sometimes. Probably some of them, no? Okay. I won't names of the shows, but a lot of people watch medical shows for the love stories and the drama that goes with it. And you can learn a thing or two, actually, if you do. Okay, so doctor, we're just going to take a short break to remind people more about the things that Makati Med has in store for them.
Thank you.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. Jacinto from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable through Makati Med Care Access at 𝗥𝗲𝗁𝗶𝗵𝗹. Available for outpatient care services, our 𝗥𝗲𝗁𝗶𝗵𝗹 site offers consultation and diagnostic procedures such as medical assistance, hospital admission assistance, blood pressure monitoring, laboratory tests, and X-ray, among others. This is really convenient for those residing in Makati and nearby areas who do not want to go to the hospital to have these treatments and procedures done. We believe that access to excellent quality and compassionate healthcare is a basic human right, and we at Makati Med 𝗥𝗲𝗁𝗶𝗵𝗹 are doing our best to make this possible to more people. We are open from Monday to Saturday at 8 a.m. to 5 p.m. at the third floor of 𝗥𝗲𝗁𝗶𝗵𝗹 in Makati City. For inquiries, you may reach us at these numbers. We look forward to serving you here at Makati Med Care Access 𝗥𝗲𝗁𝗶𝗵𝗹.
You're back with Healthline, keeping you healthy, moderated by Nicole Jacinto.
Hi, everybody, and welcome back to Healthline with Makati Med. I'm your host, Nicole Jacinto. We're talking about kidney stones today. We are here with Dr. 𝗵𝗍, and we're about to go into how you treat or how he and others treat kidney stones. Possibly surgery and all that. We'll ask him in just a minute. But before that, I'd like to, tell everyone and congratulate Makati Med because they recently won the Tower Awards, no? The Makati Medical Center's nursing workforce and bed management team has been honored as one of the recipients of the prestigious 2023 the Outstanding Workers of the Republic, or Tower Awards. That is a big deal, folks, because that means the nurses in Makati Med, and as they said, the bed management team. So, nurses work hand in hand with orderlies and others, and they're there, they're there in the ER, they're there in the operating rooms, they're there when you're in your bedrooms, they're there caring for everyone. So they won the Tower Awards, and this remarkable achievement comes under the Innovative Team Services category for healthcare for their outstanding project in the COVID-19 dashboard. So, the nationwide awards, which is organized by Rotary Clubs of Manila and the People Management Association of the Philippines and the Department of Labor and Employment, celebrate employees who have made exceptional innovations across various sectors. And so happens that the COVID-19 dashboard project that was presented by Makati Med's Nursing and Patient Care Services Division, which is composed of the nursing workforce, budget and informatics department, bed management officer, and these are won these awards by presenting the COVID-19 dashboard project. And Makati Med itself would like to give a shout out to their own people, their own workforce, to Wilson S. Albay, RN, that means registered nurse, along with the workforce management officers, Abby Laureen E. Enriquez, RN, Justine Cristel B. Balacano, RN. They were also supported by the workforce management officer, Doris V. Oreta, RN, and additionally, Charissa S. De Luna, RN of NWBI, Head of Nursing Quality, Arthur Kevin V. Castor, RN, and the Head of Admissions, Miss Marites M. Colorado, played key roles within the NPCSD Nursing Support Services. So, this project that they had revolutionized Makati Med's records management team, and they had a dedicated bed management team that was formed to streamline the admission process. It's very important. If you've ever been to a hospital, it takes so long sometimes to get admitted, and you're stuck in the ER, and it's very, very stressful for not only the patient but the family sometimes. But this thing that they have done has helped streamline that process and coordinate bed movement from the ER floors to the inpatient floors. Sometimes when you're in the hospital, they say, we're just waiting for a bed, and it takes a whole day. So these people have made it so that the bed is there. The bed is always available. That's very important. Just think of the logistics of a hospital and how it works, no? And they have a bed prioritization Viber group. It involves multidisciplinary team that they all work together. They discuss bed allocation, availability, and prioritize based on patient assessments and severity. So that this resulted, when they did all this resulted in faster turnaround times for admissions. That's actually really important. If you're a patient, you would understand that and appreciate that. And also, they are recognized, the recognition that was bestowed on Makati Med's nursing workforce and bed management team is a testament to their unwavering commitment to excellence and their exceptional contributions to the healthcare industry. No, so because of the COVID dashboard project, which is groundbreaking, the team demonstrated their adaptability and dedication to addressing the challenges presented by the pandemic. So, this team, they really got they put in all they had, and because of the pandemic, of course, you have to put people with COVID here, others there, others who need surgeries. They really contributed something that is now also being used to make everything more efficient. So congratulations again to the Makati Med nurse workforce and the bed management team. And your management, or Makati Med, is so proud of you for winning those awards. Okay, let's go back to Dr. Peñaranda. Thank you, Doctor, for giving us the time to congratulate your nursing workforce and that project. I'm sure you know some of these people, and that somehow, it has also impacted you and your practice. Okay, so doctor, let's get back to the nitty-gritty of how you treat kidney stones. I mean, what are the options for treating them? You did mention surgical procedures. Do you want to start with that?
Okay, maybe I should include Nicole.
Yes.
The management first for
Yes.
pain,
Okay.
no, or discomfort associated with kidney stones, no,
For sure,
because
yes, please. Okay, if you have kidney stones, doctor, how do you manage your pain? Because you said it's excruciating.
correct.
So, how do you do that? How should a patient do that?
Okay. So during an acute episode, when you say acute episode, sudden, no, or renal colic, we call it renal colic. That's the pain associated, no, or the term associated with pain caused by kidney stone, renal colic, no. Usually, of course, we do pain control, no. Some general practitioners, maybe some of our colleagues, most especially non-nephrologists, they give NSAIDs, no. Those are non-steroidal anti-inflammatory drugs. Yung mga mefenamic acid, 𝗥𝗲𝗽𝗆, Celebrex, or ibuprofen, mga ganon. Those are called NSAIDs, no. Now, me, I prefer, no, giving NSAIDs in a short period of time only.
Short period of time only.
Like for example, 1 tablet or 2 tablets, because most often than not, when the patient calls you, I mean, if you're not so familiar with the history, you don't know whether the kidney function is okay or not.
And NSAIDs can affect that?
Correct. Yes. No. Especially when a patient is dehydrated. What we call that is when the patient has volume depletion. Kulang sa water, for example. No, patient had diarrhea. And then, unfortunately, also had renal colic. No? So, volume, NSAIDs per se will intervene, no, in the auto-regulatory response of the kidney, no, to induce acute kidney injury. So, if you have a poor kidney function, maybe acute, no, caused by volume depletion, no, and also if you have chronic kidney disease already, and you take NSAIDs, no, that would do more harm than good. No?
Oh, okay. So that's great, doctor. It's such a great warning. I don't think people realize that. They don't talk about that much. So if you were to encounter a patient, of course they're really in pain. You want to treat the pain. Pain management. Other doctors may say, why don't you take non-steroidal anti-inflammatory drug NSAIDs, but you would only give it for like 1 day and check out the patient right away.
Because if the pain doesn't go away after 4 hours, then that would be an indication that you really have to go to the emergency department. No? Because chances are patients whose pain doesn't go away, it ends that they take another one.
Yes.
They self-medicate.
How exactly are NSAIDs bad again? How you mentioned they interfere? How do they interfere with the kidney function? Yes, or the kidney doing its job?
You see, our kidneys, no, are blessed with prostaglandins. So those are the substances, no, which promotes the flow of blood to the microcirculation of the kidneys, for that prostaglandins. Now, these NSAIDs are prostaglandin inhibitors. So when you inhibit prostaglandin, what would happen is it will constrict your small blood vessels. Therefore, it will compromise the circulation of the kidney. More so, for example, if you are volume depleted, dehydrated ka na, no? And then you're losing a lot of fluid. So the auto-regulatory response is really to vasoconstrict, no, to preserve, no, the normal pressures. No, you add to that and said it would constrict more, and you'll end up going into acute kidney injury because there will be not much blood flow to the kidneys anymore. No, so decrease in blood flow, of course, will compromise your GFR, we call the glomerular filtration rate, or in simple words, the kidney function itself.
Doctor,
So
that's
that's
such a good point you made. I'm so glad you said that because most people will really just take another one, over the counter, avoid going to the doctor right away, or it's not convenient right now. You mentioned the 4 hour window. If the pain does not go away in 4 hours, or if it comes back, then and usually people will pop an NSAID or something that helps the pain in
correct.
4 hours. Reports that you should go to the hospital already and have it checked.
Yes, yeah.
How about
Because
how about opioids or
yes, that's what I'm supposed to add.
sorry, doctor, go ahead.
The opioids are good pain. It's good for pain control, because it does not contribute, to acute kidney injury, meaning it will take away the pain, but it will not compromise circulation to the kidneys. So it controls the pain, and it also is not contributing to the acute kidney injury or say deterioration in kidney function. Because the two important things that we should remember is those patients who have pre-existing kidney disease. When we say pre-existing, na medyo the creatinine are not normal anymore due to some other things, diabetes, hypertension, and those who are prone to acute kidney injury like dehydration,
Yes.
those are the two things that we would like to consider. Good thing if all those patients have a normal GFR, so 1 or 2 or 3 tablets. I mean, won't really do too much harm. The problem is those patients who are afraid to go to the hospital. They will keep on popping NSAIDs.
Popping NSAIDs. When actually, I mean, if they went to the hospital and saw you, then you would give them an opioid because it doesn't interfere and with the function of the kidney, and it also takes away the pain because you want to address the pain, manage the pain that the patient is feeling. So, actually, doctor, I'm so glad that's a great point that you made because, of course, opioids, you need a certain license, you need a prescription. And I don't know why, I don't know, it seems to be like everyone is sort of against opioids and pain management, but they are necessary.
Oh, yeah.
I mean, when you try to, your doctor prescribes an opioid and you go to the drugstore, they're like, like it's too much. You need it. I don't know. They're trying to push you to their products, and some people are allergic to NSAIDs. So anyway, thank you for mentioning that. So if you have a lot of pain, that a doctor like yourself or you can address that with the proper medication.
That's right.
Knowing that and can check you out and evaluate you. So that's a good reminder. Doctor, we just have a couple of comments here on Facebook from Emmy Luna Madeja. Thank you for sharing. God bless you both. So thank you, Emmy Madeja. Roger Yu says, watching all the way from Sydney, Australia. Dr. Peñaranda, very informative. Thanks very much. So, doctor, you have a fan watching from Australia. Thank you, Roger, and Emmy for sending those messages. It always lets us know that it always makes us happier to hear back or to hear from our listeners and viewers. Okay, so doctor, you've talked about NSAIDs, opioids, and that's so important. Because as you said, we just keep popping it, and then you're doing damage to your kidneys. When a patient now goes to you in the hospital, and let's say you've given them some something to manage their pain that will not interfere with the kidney function. So apparently there are painkillers or pain relievers the NSAIDs, basically the non-steroidal anti-inflammatory drugs that interfere with the function. How do you can you walk us through like how you
Options.
would yes the options for treatment and the process.
So treatment options for kidney disease. So No, they normally those stones which causes pain is usually lodged in the ureters. No, again, the ureter is the tube which connects the kidney to the urinary bladder, and then eliminating it out through the or the what's called the urinary bladder. No. So the likelihood that the ureteral stones depends upon the size, no, and location of the stone. Smaller and more distal stones are more likely to pass without intervention. When you say proximal, it's I would say distal. Sorry, it's near to the 𝗂𝗏𝗏 junction and away from the kidneys already. And smaller stones will likely to be passed, without surgical intervention,
Wow, because doctor, a lot of people ask that, can the stones pass naturally? But
yeah, stone size is the major. Sorry.
No, sorry, go ahead.
Stone size is the major determinant of the likelihood of spontaneous stone passage. Although stone location is also important, as I've said, the stone is away from the kidney, the likelihood of passing out spontaneously will be high. Most stones less than 5 millimeter in diameter pass spontaneously. Ilalabas mo yan pag less than 5, and it is through the CT stonogram that you will know the size. So you will tell your patients, oh, you're lucky, your stone is not that big. Chances are baka you're going to pass it out spontaneously. For stones larger than 5 millimeter in diameter, now there is already a progressive or a less likelihood that you can pass it spontaneously, more than 5 millimeters or 0.5 centimeter. Now, if it is more than 10, it's already more than 1 centimeter in diameter, chances are you will not pass it anymore, and you need the urologist already. You need a surgical intervention. And for those stones which are more than 5 and less than 10, meaning 5 to 10 millimeters, we can deal with the stones using a medical expulsive therapy, MET, by giving medicines. In patients, medicine, yeah. For ureteral stones more than 5 millimeters and less than 10 in diameter, we usually give alpha blockers, yung tinatawag na tamsulosin, 0.4 milligrams yun for up to 4 weeks, to facilitate a spontaneous stone passage, Now, most evidence exists, that for distal ureteral stones, yung malalayo na sa kidney, we usually give alpha blockers, to facilitate the elimination or the passage of these stones. Now when patients are given alpha blockers for up to 4 weeks, we then re-image, if possible, the spontaneous passage, if it has occurred or not. We call it as a confirming stone passage. You confirm whether the stones has passed or not, And then to confirm the stone passage, it doesn't mean that if there is no pain anymore, you might have passed the stone. That is not true, It is not necessarily consistent with stone passage if you are already quiet. Wala nang pain, Now, in patients who have not passed their stone after 4 weeks of medical expulsive therapy, we again obtain an imaging study, like a CT stonogram again, and then we refer to a urology for intervention this time, because that stone, as I've said earlier, could be a potential source of kidney damage in the future if that is not addressed. So for the procedures that can be done, of course, there are a lot. The urologists usually, they are subjecting the patient to a what we call as a stenting no?
Mhm.
Or a 𝗂𝗏𝗃𝗃, or shockwave lithotripsy, no? Those are the procedures which the urologist will usually offer, no? Now, an urgent urologic consultation is warranted, no, in patients, no, with urinary tract infection pag may infection na. When there is an evidence of infection already and acute kidney injury, meaning tumataas na yung creatinine, nako,
And you can
kailangan na
test with the
talaga.
blood, diba? You'll take a blood test again.
So that would be already an indication that the urologist will intervene, no? So the current option for therapy of stones that do not pass, no, those stones which are more than 10 na or 1 centimeter and above na, hindi na sila mapapass spontaneously. So the urologist might want to offer a shockwave lithotripsy, a ureteroscopy with laser lithotripsy, and a percutaneous nephrolithotomy, no? And in rare cases, laparoscopic stone. Now, what are these things that I am mentioning? Shockwave lithotripsy is the bombardment of shockwaves to the kidneys with the hope of crushing it, no? So we have it here also in MMC, no? Shockwave lithotripsy, ureteroscopy with laser lithotripsy, that is the insert scoop, no, in the organ of the male or the female, no, and then is being guided up, and then by direct visualization, ikikita mo yan sa scope kung saan nalalodge ang stone, and then they hit it with a laser, no, so that hopefully it will disintegrate. And after that, they put a stent, no? A stent, yung parang artificial ureter, para hindi magsara kaagad yung yung ureter, yung native na ureter. So those are the things, no, mga tinatawag natin, we call the first line management options, no, for ureterostones that require removal. Okay.
Just to see, I just want to see if I understand this correctly. And please interrupt me anytime to tell, to correct me, tell me if I'm wrong or add anything. When a patient comes to see you, of course you will get the urinalysis, you will take the blood test, and you prescribe a medication if they're in a lot of pain, because that means the stone is in the ureter at that point. And it will be an opioid more likely and not an NSAID, because it interferes with the kidney function. So the patient comes to you, and if you find out that the stone is small or distal, and distal further away from the kidney, stones can pass.
Correct.
So you can tell them, would you tell them to drink a lot of water, buko juice, or whatever, or you give them medication for it already to pass.
Yes, correct. Yeah.
The medication for it to pass, and then if the stones are 5 to 10
millimeters,
you also give them another set of medicine. So the first line of treatment is, are they oral medicines?
Yes, tablets.
So they don't have to freak out that right away. Maybe if you're lucky than others.
Yes.
Size. So once it gets to 5 to 10, between 5 to 10, then you need another type of medicine, and you usually give it to the patient. But then you check again with a CT scan, maybe after 4 weeks.
Correct.
Just because there's no more pain, doesn't mean that the stone is gone. And then
correct.
It may have, I don't know, gotten a bit smaller, but it's still there, and you need to address it. Okay, so you have follow-up checkups for that. And then when a stone is big, basically 10 above, or 1 centimeter, you said already. No?
Yeah.
Yes, I get so confused with the metrics.
1 centimeter. More than 1 centimeter.
You already see you work hand in hand with a urologist. because I guess this is an emergency. You consider this an emergency, and your options are either a ureteroscopy. That's when you insert I guess
a scope
into the male or female organ, and then they see they follow and they see where the kidney stone is or kidney stones are, and they use a laser in the hopes of breaking it down.
Yes.
Okay, and then they may put a stent. Are there cases where they put a stent without using the laser, or they
Yes. There are instances where they only put a stent.
Okay, so a stent would be something like to open it up.
No, we call it a double J. So because the one end J shape, the other end is also J shape. Parang it mimics the anatomy of the ureter, so that it will hook up to the kidney and hook down to the ureter. So it would be a temporary passage of urine.
When you get a stent, do they ever have a chance to take it out? Do you take it out after?
Oh, yes. They should. It should be taken out because it would be a focus of infection later on.
Okay. And then there's also the shock wave where you
Bombard.
it's like sound waves, no? But it's not loud. You bombard it so
Yeah.
crashes.
It is directed specifically to the stone, without destroying the other surrounding areas.
Which surgery to apply, and also there's a chance of laparoscopic surgery where I guess you go in through the through a vein, or do you go in through the female or male organ, or through a vein and like?
No, there is just a small puncture in the abdomen, like 3 punctures, and then you insert your laparoscope, no, and then the surgery is being performed there, no. Through the imaging studies, there's a big like a TV there where the doctors can see what's going on, and directly to the scope they can visually have a direct visualization.
Choose which surgery.
I'm sorry again.
To choose one surgery or treatment over the other.
Oh, it all depends on the discretion of the urologist.
Oh, okay. All right. Doctor, we are running out of time. I had so many more questions for you. And actually, like some announcements for Makati Med, congratulating them on other endeavors and achievements. Maybe I can do that next week. And but I do have a comment. Oh, okay. I'm just gonna take a short break, doctor. And we'll be right back.
Thank you.
You're listening to DZRJ 810. You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. 𝗛𝗲𝗁 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable via Makati Med Mobile Care Access. As the name suggests, this service is mobile, which means that we go to where you are. Mobile Care Access deploys a team of professionals for face-to-face consultations and to conduct basic laboratory and diagnostic procedures, as well as vaccination and testing, depending on your needs. We can go to any location of your choice within the metro and readily offer these healthcare services to communities or groups. For added convenience, different modes of payment are available, including HMO benefits for those with a valid letter of authorization. We believe that access to affordable, quality, and compassionate healthcare is a basic human right, and we at Makati Med are doing our best to make this possible to more people. For inquiries, scheduling, or pre-registration, you may reach out to us at the following numbers. We look forward to coming to you and serving your community with Makati Med Mobile Care Access.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
Okay, welcome back to Healthline with Makati Med. And doctor, we do have more time. We need more time to ask some of those questions and discuss a bunch of those things. Before we get to that, we'd also like to, there's some remarkable news that we can share with you today about Makati Medical Center's stroke team in the section of neurology that has achieved an extraordinary feat. So they've been awarded the platinum citation by the Angels Initiative for Stroke Management for the second time. So it's the second time they've gotten that award. And this recognition by the Angels Initiative Initiative for Stroke Management is organized by the World Stroke Organization. So it acknowledges hospitals around the world for their excellence in stroke care. And the award the awards are given by platinum, gold, and silver. And Makati Med Stroke Team consistently showed their expertise and unwavering commitment to providing exceptional stroke care. That's very important. A lot of Filipinos get strokes, and it's something that scares all of us because it can happen anytime. So at least we know that the dedication to this mission of Makati Med delivers the highest quality healthcare to their patients. Okay, so congratulations to Makati Medical Center Stroke Team for achieving the platinum citation once again. Oh, so they got the highest. Okay, and another thing, the Makati Med receives Investors in People Gold Award. Okay, so this is different. This is a kind of award where you invest in your own people, not just this equipment or that equipment. No, Makati Medical Center achieved a milestone in people management practices, and it recently got an award, the prestigious sixth generation Investors in People Gold accreditation. Makati Med is the first hospital in the country to get this recognition, and it's only the second organization to achieve gold status on their very first assessment. I guess, they keep assessing you, and on the first assessment, Makati Med got it. Now, this achievement, it demonstrates Makati Med's commitment to their employees. So, and how they dedicate and how they create a nurturing environment for work, and how it has been successful in establishing connections with people. So not just with equipment and all of the latest cutting edge stuff, but connecting with people and providing abundant learning opportunities. And talking about investing in people, the evaluation revealed that Makati Med's practices are rated as advanced or established. So it surpasses the average rating for Investors in People. So this just goes to saying that Makati Med really puts a lot of effort in investing in their own employees. Okay, so congratulations for this exceptional achievement. Doctor, we have a comment from Mali Chua. Thank you, Dr. Peñaranda, for your informative and helpful talk. More power to you. So
Thank you, Mali.
Okay, so that's great, Doctor. Okay, let's get back to what we were talking about. How would you decide between, you said it's the urologist who will decide. Do you get to have you gotten into a fight with a urologist over, over what procedure?
We don't want to fight them, or else our patients, they won't remove the stone to our patients.
Do patients get, I prefer this, why can't you do it with this? Does that happen sometimes?
Because there are indications, and contraindications. In general, the main indication for surgical treatment includes pain, infection, and obstruction when the urine flow is compromised already. There is no specific surgery, required for asymptomatic patients. Particularly those that are less than 5 millimeter in diameter. However, surgical stone removal may be reasonable for patients when they are asymptomatic. Those who are frequent travelers, for example, pilots, those who are contemplating to get pregnant, or those who wish to avoid symptomatic stone episodes. So even though they are asymptomatic, sometimes a surgery is done per request of the patient.
Basically,
Or
it gets
yeah,
discovered that they have stones, even though they don't
yes,
feel it. It's a symptom. How does it
uh,
usually get discovered? Like,
through
oh,
imaging
imaging.
study, yeah, and
So
by a pain, usually pain.
pain, pero
It may,
not that much. And
yeah,
then,
it may not be very severe pain. Uh,
but then of course, the doctors know, even
mm-mm.
general practitioner, like, back pain, this person. So I think let's check your kidneys. And then it so happens. So that's how it usually gets discovered, by back pain or pain of some kind.
Yes, correct.
Or maybe if
Uh-uh.
taken a CT scan for something, other reason, then you're like, oh,
Yeah.
kidneys.
An incidental finding.
Yes, additional finding.
Uh,
Okay. So, doctor, in your practice, have you seen that any? Oh, you mentioned pilots. Is that because they stay at their seat and don't urinate often? Is that the reason why?
Not necessarily, because the main complication for that is usually you get urinary tract infection, because if you try to hold your urination, of course, it will be stagnation of
Mhm.
urine. So it will be a focus, of infection, because normally we want to eliminate,
Mhm. So we
those
should.
things.
It's okay. Like if we drink a lot of water and pee all the time. I mean,
Oh
it depends on what you
yes,
drink. So it's okay. So that's a good practice. You don't
yes,
overdo it, but
yeah.
there any, like, how about, we always hear the 5 to 8 glasses recommendation for of water for not to get dehydrated. Is there any, like, prescription or whatever to follow for avoiding
Mm-mm,
any tips? Or maybe we can circle back to that later. uh,
yes,
okay.
like preventive therapy, no?
Yes, preventive, how to prevent stones, getting kidney stones. Doctor, do you find in your practice and the people you've treated, is there any demographic, like, are there more men than women, or, people of more age, or are there biological factors, or like any of those, etc., that make someone more prone to getting kidney stones? Or what have you found? Like, who usually gets them? Is there anything prominent?
Yes. Usually, according to the studies they've done, the males usually get more stones, than females. And those older patients, they usually get stones, than younger ones, And of course, those who are usually exposed to what you call this, exercise, physical exercise, especially during the summer months, they sweat a lot, and then they don't seem to drink, the necessary fluid requirement, uh, but usually stones, are common in the
Okay.
whites, less with Hispanic and blacks.
Okay. So
Mm-mm.
Caucasian, Hispanics, and African Americans or blacks, they get kidney stones more often than
No,
Filipinos.
less.
Yes. Okay.
They less. Filipinos, Filipinos per se, they maybe due to the lifestyle,
Mm.
of Filipinos. Our culture will always involve us with eating too much, masarap na pagkain. No, and of course, if you are, so we say, on the heavy side, your BMI is high, and then you are diabetic,
Mhm.
most likely, you will develop kidney stones, not 100% now, but there is a strong possibility, It all boils down to the lifestyle, of the patient, So
So,
it's very important that you have a increased fluid intake, dietary modification. You try to eat less salty food,
mhm.
like 100, less than 100 MEQ, or 2,300 milligrams of salt, or less per day. And of
Mhm.
course, weight loss, Mm-mm.
Yes.
Yeah.
Do you mean, if you are heavier, you are more prone to kidney stones?
Yes. Yeah.
Mm.
Because of the chances of you developing a metabolic syndrome. Say metabolic syndrome, your uric acid is elevated, your sugar will be elevated, your cholesterol will be elevated. So those, I mean, that is a vicious cycle, no?
And it all works and affects.
Yes, and it will make you prone to develop kidney stone.
Of course, so as you said, as Filipinos, we like to eat a lot.
Yeah.
Sugary drinks or sodium.
Yes, calorie-containing drinks, sodas.
Yes.
Yeah.
I'm guilty, Doc. You said. Okay. Doc, Rose Estrada says, thank you for this informative discussion.
Thank you, Rose.
Okay, Doc, I don't know if you'd like to discuss what steps can be taken to monitor kidney stones or recurrent kidney stones, or just anything that you'd like to say to people people out there, our audience basically right now, anything you'd like to say or any advice you'd like to give.
Yeah.
Kidney stones are prone to it, or
Yeah, maybe I'd like to give some general preventive measure for all stone types, no? All stone types, no? Of course, the preventive measures are applicable to all patients with kidney stones, independent of their stone type or their individual risk, no? Number one preventive measure is fluid intake, no? For all patients with kidney stones, no, we usually suggest sufficient fluid intake to consistently produce at least 2 liters of urine per day. So to reach this goal, the best strategy is to recommend how much additional fluid the patient should drink based upon his or her 24-hour urine volume. As an example, no, if the total urine volume is 1.5 liters, yung ihi mo per day is 1.5 liters, then we usually recommend 2 additional glasses of fluid each day. 1 glass approximately 240 ml, no? 2 additional glasses of fluid each day to reach the goal of at least 2 liters of urine output per day. And then we usually tell our patients to distribute the fluid intake throughout the day.
So this is a good measure for those who have stones, and for those who maybe want to prevent them. I'm sorry, doctor, I'm going to have to, wow, we ran out of time. Is there anything you'd like to say to, so much more we could discuss. Please come back on the program another time so we can talk about, more about preventive measures and all of that. I really thank you for joining us today. I'm sorry I'm getting killed by my producer right now. Like, so,
okay.
But is there anything you'd like to say to wrap up?
Three cardinal, three cardinal do's and don'ts. First, do increase fluid intake, a lot of water, don't dehydrate yourself. Second, avoid salty food, another cardinal don't. The third one, avoid high protein diet. Meat of beef, meat of pork. That's all.
Okay. So great, doctor. Okay, so your advice, people, I'll just repeat it. Increase your fluid intake, drink more water. Don't be saying, I'm increasing my fluid intake by drinking scotch or beer. And then
no.
Avoid salt and avoid a high protein diet. Thank you, doctor, for being on the program.
Very welcome.
I hope you come and join us again so we can talk really more about the preventive measures and go through it. And just anything else you'd like to discuss about your specialty. The cases of having kidney disease or kidney stones and just problems with kidneys in the Philippines are really quite prevalent. So this is great. Thank you for being on the show, doctor.
My pleasure, Nicole. My pleasure to everybody.
Take care. Come back soon.
Sure. Thank you. Have a good night, Nicole. Right. Thank you for having me again.
Oh, I enjoyed it so much. Come back soon, doctor. Thank you, everybody. Tune into Healthline with Makati Med next Monday from 5 to 6:30 here on DZRJ Radio Bandido. Okay, bye, doctor.
Bye-bye.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.